you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Pericardial tamponade, cases time. Before we jump into that, though, just a couple quick housekeeping things. Both volumes of Introduction to Bedside Ultrasound 1 and 2 have been updated in iTunes recently, so if you have those, be sure and update. There are some fixes. Also, if you're using the iBook on your computer or other device through inkling.com, Volume 2 is now out. It's been a bit of a process getting it converted over, but it's now available for those of you who don't have an iPad or just prefer to have the book on your computer or iPhone or whatever. And remember to apply for the FOAMed scholarship that the funds from the sale of the books go to support. Speaking of iBooks, if you guys haven't heard, ACEP came out with an iBook on trauma ultrasound recently, which is pretty awesome.
Now, obviously, we're excited to try it out. We love ebooks, and we think it's definitely the future.
We can't really see a future where we have big hulking books to describe procedures and disseminate information when the same information 1,000 times over can fit in your pocket. So we're pumped when people embrace this future of education and put the information in our pockets.
Especially when such illustrious people as those that produce this ebook are doing it. So we got a hold of it as soon as we could and decided to do a book review for you here on the podcast because, like we said, well, we love books. I think one day I might actually read one.
Now, some may think that because we also have an iBook, there would be some competition here, but that's crazy. My love for books is too strong. In fact, there's nothing that irks me more than people who burn books. I've never understood that until I read this book.
Yeah, I gotta say, my favorite part about this book was when I took a break to go take a dump.
Yeah, the book is free, and after reading it, it's actually pretty clear to me that it's extremely overpriced. I can't think of a number big enough that they'd have to pay me to read this thing again.
Yeah, actually, I was trying to read this book while I was driving to work one time, and I literally took my seatbelt off, hoping I'd get in a car accident and die.
Just to be clear, the fact that we have an ebook in no way prejudices our opinions, but a few times while I was reading this, I wasn't sure if the authors were high on bath salts or if they just threw a Mac in their ED psych room and asked a patient to start typing. I mean, no offense to the psych patients.
I am in no way prejudiced by the fact that I have my own iBook, but one gripe that I did have about this iBook is that when I opened it, there was a naked picture of Mike Stone on the inside cover.
Yeah. I wasn't sure if their title, Fast, was about the scan they were attempting to teach or how quickly you should delete this from your phone if your 3-year-old accidentally downloads it.
I mean, seriously, guys, Miley Cyrus is the fast pelvic model?
I honestly lost all respect for Apple for approving this. It's several rungs down the ladder of respectability from the 15 to 20 fart apps that I have on my phone.
And one specific gripe about iBooks in general, but specifically this one, is that a big disadvantage of the iBooks format is that the multiple gesture touch actions just don't leave two hands free to give it a good double flip off.
Obviously, we're joking here. We devoured the iBook and loved it.
And it really is free. You should download it and tell everyone you know about it.
Even if you already have our iBook, this is completely different. It's very focused on trauma ultrasound specifically.
It's beautifully designed and really goes into trauma ultrasound much more deeply than we do in Introduction to Bedside Ultrasound.
So kudos to Bob Jones, Mike Stone, Rob Blankenship, and company who produced this thing.
We both have it, and we're going to encourage every medical student and resident we know of to download it.
Great job, guys. This should be used as a model to others who want to improve the world of medical education with FOAMed. And Mike Stone, sorry, dude, we couldn't resist. Sorry. Case number 1. Mike, you got a 38-year-old female here with a history of diabetes, chronic kidney disease on dialysis. All of a sudden, she became acutely dyspneic and hypotensive during dialysis today, and she was sent down to the ED from the dialysis clinic. So, obviously, they've just taken off too much fluid, right? That's why she's hypotensive. You see her vitals here, a little bit hypotensive, a little tachycardic, no fever, satting, borderline. What do you think? What do you want to do, Mike? How do you want to evaluate this lady?
I think I'd probably give her 2 liters of fluid and intubator.
We're going to take care of her in a little more nuanced fashion. Let's take a look at her heart. So, all right, she has pericardial effusion. I think you can see that. Mike, what do you think? Tamponade, yes or no? Because that's what matters. Doesn't matter how big this is. She's on dialysis. So she's probably got a chronic effusion. We don't know if this is new or not. Our question is it causing problems for her? Does she have tamponade here, yes or no, based on what we learned last podcast?
Let's see. So you told me her blood pressure wasn't really that low. I mean, it was kind of low, saggy. But looking at this echo, there's a pretty big effusion, and it looks like there's a little man jumping up and down on top of the trampoline of the right ventricle.
So I agree. Early tamponade, you can see it there, that right ventricle, the effect that effusion is having. And if we want to confirm, get a little more information, because again, this is slightly complex. She's got a chronic effusion. We'll take a look at her IVC also, see what's going on. Because our question was, first, did she maybe get too much fluid taken off in dialysis? So when we look at her IVC, here's what we see. Big, distended, no, not collapsing at all. So this kind of confirms the fact that she probably has obstructive shock, early tamponade. So what really probably happened in this lady is she got some fluid taken off. She already has an effusion there. And with that effusion there, they decreased her preload just enough to actually cause that pericardial pressure to be higher than the pressure in her right ventricle. So you're getting a little bit of tamponade. So I really like this case too because it illustrates a point. You look at her IVC. If you just looked at her IVC in isolation here, weren't thinking about anything else, what would you think about that as far as your management? We think about a patient being volume responsive if their IVC is collapsing, and there's no collapsing there, so you're thinking just IVC in isolation, no fluids for this patient. But actually, she's preload dependent. She needs that extra preload to overcome that pressure in her pericardial sac. So giving her a little bit of fluid here would actually be good. We'll temporize her and probably get her pressure to come back up, and then she can have this effusion drained in a more controlled environment, not in the emergency department, even though there was a little bit of tamponade. The right answer here is probably some fluid first, and then call CT surgery to take care of this.
So I was right about the 2 liters of fluid in intubate?
I don't know about 2 liters. You're right about fluid, but I'm not sure about 2 liters in this patient. Probably would have been fine, but probably better to get the information beforehand. That takes how long? How long did that take to get a quick look, quick peristernal look and quick IVC look? Less than 60 seconds. Probably less time than it would have taken to hang the IV fluids. Case number 2, 53-year-old guy, history of irregular rhythm, had an ablation 4 days ago. Now he's presenting with shortness of breath and chest pain with movement. Vital signs look a little familiar, slightly saggy, a little tachycardic at 113, no fever, stating 91%. Mike, what are you thinking just off the bat here? This guy had an ablation 4 days ago.
Well, his ablation probably didn't work, so we probably need to get an EKG.
All right, you're killing me. So what I wanted you to say was this is a complication of ablation. Pericardial effusion and tamponade acutely. From the ablation, they nick a little something, get some bleeding, they get an effusion and tamponade. So here's what we see when we look at this guy's heart. Definitely has an effusion. The question is not effusion, though. Is it tamponade or not? What do you think, Mike?
Well, it's tough because there's a really big effusion there. So if size mattered, I'd be pretty worried. But I guess, I can't see the right ventricular free wall that well, but I can see the right atrium pretty well, and that doesn't really look like it's collapsing to me.
I would agree. And remember, we said before that the right atrium actually collapses before the right ventricle does. So as big as this effusion is, I doubt this is acute. If this was acute, there would probably be some physiologic changes from it. So the ablation thing is kind of a red herring, but we really want some more information because we really are worried about this being acute. Now, does this patient have tamponade? We don't think so from this image, but let's get another image. No reason to just get one image if there are others available. So here we see the effusion again. Pretty big effusion. Mike, what do you think about this view?
So again, a pretty big effusion. It's definitely pericardial because it's pointing anterior to the descending thoracic aorta. Looks like the LV's nice and big and filling pretty well, and maybe a little hyperdynamic, but not too bad. And then I guess the RV free wall is the next thing to talk about. Doesn't really look like it's collapsing to me.
Looks perfect to me. So this confirms what we saw in the last view. No signs of obstructive shock from this effusion, not tamponade. Just for fun, we take a look at the IVC as well. And what do you see right there, Mike?
Definite collapse of the IVC.
Yeah, complete collapse. And as Mike mentioned before in that one study, not a huge study, it'd be pretty difficult to actually have obstructive shock in this completely collapsing IVC. Pretty much impossible. So more confirmation of what we thought. We feel even better at this point. This patient's mild hypotension is not from obstructive shock or tamponade. Case 3, 72-year-old female with history of chest pain for the last 7 days that radiates to her back. She complains of a tearing chest and back pain that feels like she's being ripped in two. Does that sound like anything specific, Mike?
Probably GERD.
GERD or aortic dissection. You probably want to make that diagnosis. I mean, this is a medical student question, the being ripped in two, tearing chest and back pain. It's aortic dissection, right? I don't know if you all have seen a case of tamponade from aortic dissection, but I've actually seen a couple now. It's one of the first cases that I ever saw that really got me passionate about bedside ultrasound. Mike, I don't think you've ever heard the story.
You want me to tell it?
Yeah, you could probably tell as well as I am. And I told it on the podcast before, but it was a guy that came in, no idea what was going on with him. He was just confused, hypotensive. We looked at his heart, and he had tamponade. We were getting ready to do pericardiocentesis, and then we looked at his aorta, and he had a dissection. So he's dissecting up around his aorta. So we were able to give him fluids instead of doing the pericardiocentesis and send him to the CT surgery to the OR, and he survived, but barely. He actually coded when they were moving him over onto the table, but they opened his chest, repaired the lesion, and he did okay. And the guy would not have survived if we hadn't had ultrasound there. It's one of the cases that really was a formative case for me that got me passionate about ultrasound, but it sounds very similar to this case, except he actually didn't have those complaints, but this lady does. So we're already thinking aortic dissection. She's hypotensive, a little tachycardic. We take a look at her heart, and what do you see here, Mike?
Well, I see a big effusion, and there's definitely a heart that's moving a lot in the effusion. I can't really tell you much else.
So we see the right ventricle. I can't really tell if that's collapsing or not. It's just not a wonderful image. So I want better information, better images. One thing I could do is increase the depth to try to look at that right atrium. As we've already talked about, that's going to collapse sooner than the right ventricle. And what do you see here? Slightly different view. What do you see, Mike?
Yeah, so still apical window. We've got increased depth, and I can see the atria now, and it looks like that right atrium might be collapsing.
I would agree. It looks like, as you described, the little man is punching up on that right atrial free wall in systolic collapse. So we look at the IVC, a little more information, and what does this look like?
Big dilated IVC, dilated hepatic vein, pretty clearly not changing with respiration.
Okay, so it looks like it fits, at least, with obstructive shock. And we've seen the right atrium, which is collapsing in systole. So this patient has tamponade. And it's from, knowing that it's from the aortic dissection, if we actually had a picture of that aortic dissection, this would be a case where you wouldn't want to do a quick pericardiocentesis. This patient needs preload to keep their blood flowing forward, and then CT surgery to open up and repair this lesion. It's going to keep filling if you just put a needle in and just try to take the fluid off if it's from a dissection. Case 4, last one. This is complicated. 69-year-old male, COPD, CHF, diabetes, on dialysis, presents with worsening shortness of breath and a cough over the last 3 days. He's had dyspnea on walking, has to sit up in bed to sleep. He's got a known prior ejection fraction of less than 30% with a pacemaker and defibrillator in place. Mild weight gain over the last few days, productive sputum, and feels wheezy. So what's your differential diagnosis on this one, Mike?
Pretty much everything bad that can happen to someone.
Yeah, I mean, he's wheezy, so it could just be a bad COPD exacerbation. He has to sit up in bed to sleep. Could just be a congestive heart failure exacerbation. His EF could be down. He's gained that weight. He's also got a productive sputum. Could this be sepsis from pneumonia? You see he's a little hypotensive and tachycardic, so it could be pretty much anything. A huge differential diagnosis. So let's narrow it down. We're going to start at the heart because we get so much information from a quick view of the heart. And what do you think about this view, Michael?
This is a really interesting view. So it's kind of an apical window, but you're over the right ventricle, and the RV is bigger than the LV. It's not squeezing very well. It looks really thick. And the septum is sort of pushing into the left ventricle during systole, which
Hold
is
on
weird.
a second. Is there an effusion here, first off?
Oh, yeah. I guess there is an effusion. Weird.
Okay, so there's an effusion. Now, what were you saying? You're saying RV much bigger than the LV over here. Thick, which you can see here. What else do you see?
The septum's pushing into the left ventricle, so I guess the pressures in the RV are bigger than the LV.
Okay, so this patient has an effusion. Our question throughout this has been, is there tamponade or not here? And we've talked about looking at the right ventricle to see if it's compressing, see if there's free wall collapse. And this is not a great image, but I don't really see any collapse at all. But this is such a big RV, so thick from this chronic elevated right-sided pressures. Remember, this is a COPD patient. I don't know how much pressure it's going to take to collapse that RV, but I think it's going to take quite a bit. So we may actually not see tamponade here until very late. I wish there was just some other way to evaluate for tamponade. Does anybody remember? Think back, last podcast. Mike, anything?
Man, it would be great if we could measure the velocities into the right ventricle and the left ventricle and see if they change with respiration.
Well, luckily you can, because we taught you how on the last podcast. Before you do that, you take a look at the IVC, because we can just get more information on this patient too to put the picture together. And you see a big dilated IVC, no collapse. So maybe an obstructive process, maybe tamponade. But at the same time, this patient has congestive heart failure. Maybe they're just volume overloaded is why they have a big dilated IVC. So not super helpful. Probably not sepsis as the primary cause, though, because it's not collapsing at all. So we've taken the differential diagnosis down a little bit more information for us. Now we use the mitral valve inflow velocities. So we have an apical four-chamber view. We see the effusion here. We put the pulse wave Doppler through the mitral valve, and we're looking during respiration at the variation of these peak flow velocities. And anybody remember the percentage change that's normal? We're looking at 25%. So we look at a peak here. We trace that dot across 180 centimeters per second. We look at, this is probably about the lowest peak around here. We trace this dot across, it's 120. 180 minus 120 is 60. 60 divided by 180, that's a change of 33%. Is 33 greater than 25, Mike?
No.
It's a difficult question. The actual answer was yes.
All right, so let me get this straight. So first off, I'm going to look at the heart and see if the right ventricle or the right atrium are collapsing. If I see either one of those, then I think it's probably collapse. I'm going to look at the IVC, and it's not really going to tell me that there definitely is tamponade, but it can kind of confirm my suspicions, right? So if it's collapsing, it's not tamponade. If it's big and dilated, not changing with respiration, then it might be tamponade, but I got to have some other finding that pushes me towards tamponade. And then if all else fails, and I still think there might be tamponade, but things are just confusing because the heart's got a weird, maybe the RV's big and the LV's small, or maybe there's some weird pathology going on, then I can use mitral valve inflow to sort of confirm or refute my initial interpretation.
Absolutely. Yeah, we're not giving you a lot of hard and fast rules. We're teaching you techniques, giving you tools here to be able to apply and then put the picture together. You get to be a doctor. You get to take care of the patient in front of you. Hopefully these things just help you more accurately and efficiently do that. So let us know what you think. Go out there, start sticking some needles in some pericardial sacs, and get back to us.
Thanks, everyone.
Okay, a couple things before we go. First off, medical students. We announced the medical student scholarship for CASAFES last episode, and that's full now. We had no idea there were going to be so many of you who listened and would want to come. So as much as we love being able to support some medical students here, we can't fill the whole castle with you guys. Renting a castle and flying in the best ultrasound teacher in the world isn't cheap. So we're excited about meeting our scholarship medical students, but we're officially full of med students now. We do have one more of the resident scholarships where you can come for free if you have an attending register with you. And I'm not going to announce that it's full on the next podcast, but it will be. Consider this the pre-announcement of that. As of next podcast, it's full. I'm pretty sure I'll have sent a few regret emails by then. Med students, can't wait to see you. Residents, can't wait to see you. And everybody else, kind of looking forward to seeing you too. You're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.